Should we move on to our next session? Dr. Forrest is ready? All right. So we've got an exciting couple of talks on aortic valve disease, which a lot of us are more comfortable with. So again, it gives me great pleasure to introduce Dr. John Forrest. He has been a mentor and a friend. He's Associate Professor of Medicine and Director of the Interventional Cardiology Program, Director of the Structural Heart Disease Program at Yale University. Trained at Yale through and through, college, medical college, and post-college training. He's been co-author on several of the seminal TAVR trials, especially TAVR in women, as well as TAVR in bicuspids. He has extensive experience, and he's won numerous awards as part of his early career. He's an Emerging Leadership Faculty Award, as well as Yale Advanced Emerging Leadership Program Award. So he's going to be talking to us about bicuspid valves and THV selection. Over to you, John. We couldn't hear you. I think you're muted.
Can you hear me now?
Yep, we can hear you.
Okay, sorry about that. And you can see my screen too?
Yes, we can.
Okay, perfect. Osman, thanks. It's always a pleasure to be here and to be with this audience and to speak today really about bicuspid anatomy a little bit and device selection, although I think it's more of choosing the right patients rather than actually maybe the exact TAVR device. I thought I'd start with a case here. This is a 72-year-old male who was referred to us with severe aortic stenosis, class 3 heart failure symptoms, normal LV function, no major comorbidities.
John, can you go to a slideshow, the slideshow format? So it's coming as small slides right now.
All right, let me work on that for you. Better?
No, it's
still small.
Still small.
All right, let me try one more time here. How about now?
No, it's still the same. If you could just make it bigger, maybe make your...
Yeah, I'll try.
There we go. That's better. Perfect.
Better?
Yep.
Sorry. So this is a 72-year-old gentleman referred to us, class 3 heart failure, normal LV function. As we scroll up through his anatomy here, you can see he has a type 0 bicuspid aortic valve. Certainly some calcium on the leaflet tips, but otherwise not a tremendous amount of calcification, even as you scroll down into the annulus. And low risk for surgical aortic valve replacement. And I think before we talk about what we're going to do for him, I think it's important to first recognize that it definitely is true that for patients that our early bicuspid experience when we first started doing TAVR was not great. There was lower device success, there was increased stroke, there was an increase in paravalvular leak, and there was an increased need for a second valve. But I think it's important to note that when we first started doing TAVR, the first generation valves weren't optimally designed for bicuspid anatomy. And there was a lack of understanding of favorable and unfavorable anatomy. And there was also a lack of understanding of how to do valve sizing. And so as we one of the benefits of TAVR is that there really has been very rapid device progression. We've gone from the first generation valves now to the third and the fourth generation valves, Evolut Pro into Evolut FX, Sapien 3 into Sapien 3 Ultra, and now even next generations that are in clinical studies. And what we've seen from that as we look at our rates in the United States from the TVT registry, and specifically at bicuspid data, is that there's been a drop in all-cause mortality, there's been a drop in permanent pacemakers, and the new valves appear to be working quite well for bicuspid anatomy. And in fact, also when we look at aortic regurgitation in bicuspid anatomy, we see that while about 20% of patients had moderate to severe with the initial core valve that when it was used, when we look at the Evolut Pro that has the external wrap, we see the number of patients with moderate or severe is around 1%. We've done some studies then comparing patients who have a bicuspid valve to a tri-leaflet valve and looking at how they compare. And the summary is that they actually compare very well with current generation valves. These are propensity matched groups of patients with a bicuspid or tri-leaflet aortic stenosis. And you can see that their all-cause mortality out to 1 year is just about the same. And in fact, their incidence of significant paravalvular regurgitation, moderate or severe, remains in the very, very low single digits. I should say similar data has been seen with the SAPIEN 3 valves. This is data that was presented by Raj Mokhar at EuroPCR back in 2021. Again, showing similar things with the current generation SAPIEN 3 valves. You get similar outcomes from the TVT registry. So back to our patient, right? That was the TVT registry. Patients tended to be higher risk. This is actually a patient who we enrolled in our low-risk bicuspid study. I'll spend a few minutes just talking about the Evolut low-risk bicuspid study. This was a multi-center study. It was a single-arm study. So importantly, this was not a randomized study, looking at the efficacy of TAVR in patients with bicuspid aortic stenosis and low surgical risk. The key inclusion criteria were fairly broad. Patients had to have a bicuspid valve, they had to have severe symptomatic aortic stenosis, and they had to be low risk. I think it's important to look at the key exclusion criteria. So we didn't include patients who are younger than 60. We didn't include patients who had an indication to have their ascending aorta replaced at the time of surgery. So that would be an ascending aorta that was 4.5 centimeters or greater. Obviously, patients had to have a bicuspid valve. If patients had prohibitive LVOT calcification or LVOT or leaflet calcification that made them high risk for TAVR, then they were not put into this. And obviously, they had to have other anatomy that met the indications for use with regards to the size of their sinus of Valsalva and their annulus size. The primary endpoint was all-cause mortality or disabling stroke at 30 days, and the primary efficacy endpoint was device success, which you can see defined there. So back to our patient, our 72-year-old type 0 bicuspid aortic valve. Here you can nicely see on his transesophageal echo the bicuspid nature of it. You can see some of the calcification there. I think it's critically important, and I think the most important thing that we do in our patients, actually with bicuspid disease, but all patients who are considering for a TAVR, is our CTA. The CTA is really the cornerstone of case planning. There is also a lot of discussion about how you should size the valve. Should you size for a bicuspid valve at the supraannular plane? Should you size at the annular plane? Within this low-risk study, we sized everybody at the annular plane. I will say that there may be a small number of patients who at the annulus are right in a border between valve sizes. And I think when that patient is at the border between valve sizes, it's reasonable to look at the supraannular to decide if you're going to size towards the higher side or the lower side when you're at the border. So in this patient where we're sitting with a perimeter of 82, we're sort of at that border between a 29 and a 34 millimeter valve. When we scroll up, we see if anything, it's slightly smaller above. And so we went with a 29 millimeter valve in this case. The other thing I really want to just emphasize here is that it's not about the number of leaflets. So on the top left here, you see our patient who has a bicuspid valve. And on the bottom left, you see another patient who we were evaluating at a similar time, who is a tri-leaflet valve. Now you may look at this single shot here and say, geez, both of these anatomies look somewhat favorable. You know what, maybe there's a little more calcification on the bicuspid and it's a type 0, and type 0s scare me. Not sure I really want to do that. But if you look more carefully at these patients and scroll down to the annular level, what you'll see is this. These are these exact two patients coming down to the annular level. And you can appreciate, in fact, that the patient with the bicuspid valve at the annular level has actually very little calcification. And the patient with the tri-leaflet valve at the annular level has a ton of calcification. And so in this case, as in I think most cases, it's really not about the number of leaflets. It's about the calcium and the calcium distribution pattern. And I'll let you guys decide what you would do with the patient at the bottom, the trileaflet. I can tell you that patient was low risk, and we ended up sending that patient to surgery. What I think is different between bicuspid and trileaflet patients is that with bicuspid patients, you're probably going to have more patients that have a tremendous amount of calcium. And when we talk about calcium in bicuspid patients, Yoon and Raj Makar and others have done some really nice work and defining how are we going to look at this calcium. And I think the best way to look at this calcium is to divide it into three groups of patients. The first are patients that don't have a calcified raphe or excess leaflet calcium. The second is to look at groups that have either a calcified raphe or excess leaflet calcification. And the third is to look at groups that have both. Patients that have both a calcified raphe and excess leaflet calcification are going to do poorly with transcatheter aortic valve replacement. We see the data at the bottom there out to 1 and then to 2 years. And you can see that their mortality at 2 years is about 5-fold that of patients who have no leaflet calcification, and more than 2.5 times that patients who have just a calcified raphe or excess leaflet calcification. It's also important to know that about 25% of patients fell into that category. And so what happens when you have excess leaflet calcification? Well, here's one example. This is just a still here, but a picture of an annular rupture. I think, unfortunately, anybody who's done enough TAVRs has seen an annular rupture. And so you may say, well, let's not use a balloon expandable valve. Let's use a self-expanding valve. I'll show you here an example of a case we did, excess leaflet calcification, a self-expanding valve. When there's tremendous calcification, it can sometimes be really hard for that valve to expand in there. And so here's a case where the valve just hadn't expanded enough, nothing's in there. There's so much calcium holding it in, the valve actually pops up. This is the only case I've ever had where I've had a valve pop out with nothing else in it. But this was in a case of a patient that had a bicuspid valve and just tremendous leaflet calcification. I didn't want to do a balloon expandable because I was worried about annular rupture. I chose a self-expanding valve, and I still got this result. We were able to bring another one in, put it in a fair amount more deep, and the patient did okay. But you never want to have a patient that has 2 valves in. So going back to our patient, I think it's critically important that you formalize your plan going into the case. So for this patient with this type 0 valve, we went with a 29 Evolut Pro. We did use neuroprotection. I'll talk a little bit about that. We always pre-dilate these valves, especially for self-expanding valves. It's critical to pre-dilate. We were aiming for an implant depth of around 2 to 4 millimeters, and we had our criteria for when we would post-dilate. You can see the aorta here in the bottom right there is a little bit horizontal at 65 degrees. And in those patients, we often prefer a Lunderquist wire. When you're using self-expanding valves, I would recommend that you always pre-dilate. And in fact, if you're using a balloon expandable valve and the valve is heavily calcified or very tight, I would also recommend that you pre-dilate. So here you can see on the left, we're just taking a shot of the cerebral vessels because we were using neuroprotection for this case. And there's our balloon valvuloplasty. In using self-expanding valves in these, it's important to deploy slowly and to evaluate your depth and see where you are. And here in this case, we're not too bad. Here's the angio on the right showing. But the fact of the matter is that with the current generation Evolut valves, you don't need to accept this depth. This depth is a little deeper than I think you want the valve to be. So don't be afraid here to recapture and reposition the valve. That's exactly what we've done here. As you can see on the left screen here, we start slightly higher with our valve deployment. And then on the right here, you can see we end up with a higher spot before we're going to release the valve, probably about 3 or 4 millimeters higher than we were on the prior picture. The valve is released, and we have an ideal implant, no paravalvular leak, and the valve right where we want it to be. We do often like to use transesophageal echo, and we did this a lot in the early low-risk bicuspid study to make sure we weren't missing paravalvular leak. We know TEE is the best way to look at paravalvular leak. And so this is the result from this patient, showing an excellent result and really no significant paravalvular leak at all.
Thank you, John. I'm going to have to, I think we're running into time for the next talk. It's actually Dwayne Pinto. If you have time, do stick around. There's Dwayne's talk, and then we have about 10 to 15 minutes for a Q&A, and I'm sure we have a lot of questions for you.
Absolutely.